Normocytic anemia. Basic principles. Anemia with normal sized RBCs MCV is equal to 80 to 100 micrometer cube due to increased peripheral destruction or underproduction. Reticulocyte count helps to distinguish between these two etiologies. Reticulocytes, young RBCs released from the bone marrow, identified on blood smear as larger cells with bluish cytoplasm due to residual RNA. Normal reticulocyte count is 1 to 2%. RBC lifespan is 120 days. Each day, roughly 1 to 2% of RBCs are removed from circulation and replaced by reticulocytes. A properly functioning marrow responds to anemia by increasing the RC to more than 3%. RC, however, is falsely elevated in anemia. RC is measured as percentage of total RBCs, decreased in total RBCs falsely, elevates percentage of reticulocytes. RC is corrected by multiplying reticulocyte count by hematocrit per 45. Corrected count more than 3% indicates good marrow response and suggests peripheral destruction. Corrected count less than 3% indicates poor marrow response and suggests underproduction. Peripheral RBC destruction hemolysis divided into extravascular and intravascular hemolysis. Both results in anemia with a good marrow response. Extravascular hemolysis involves RBC destruction by the reticuloendothelial system, macrophages of the spleen, liver, and the lymph node. Macrophages consume RBCs and break down hemoglobin. Globin is broken down into amino acids. Heme is broken down into iron and protoporphyrin. Iron is recycled. Protoporphyrin is broken down into unconjugated bilirubin, which is bound to serum albumin and delivered to the liver for conjugation and excretion into the bile. Clinical and lab findings include anemia with splenomegaly, jaundice due to unconjugated bilirubin, and increased risk for bilirubin gallstones. Marrow hyperplasia with corrected reticulocyte count more than 3%. Intravascular hemolysis involves destruction of RBCs within vessels. Clinical and lab findings include hemoglobinemia, hemoglobinuria, hemosideruria. Renal tubular cells pick up some of the hemoglobin that is filtered into the urine and breaks it down into iron, which accumulates as hemosiderin. Tubular cells are eventually shed, resulting in hemosidenuria, decreased serum heptoglobin. Normocystic anemia with predominant extravascular hemolysis. Number 1. Hereditary spherocytosis. Inherited defect of RBC's cytoskeleton membrane. Tethring's protein most commonly involve spectrin and chirin or band 3.1. Membrane blebs are formed and lost over time. Loss of membrane renders cells round, spherocytes instead of disc shape. Spherocytes are less able to maneuver through splenic senocytes and are consumed by splenic macrophages, resulting in anemia. Clinical and lab findings include spherocytes with the loss of central pallor, more RDW, and more mean corpuscle hemoglobin concentration. Splenomegaly, jaundice with unconjugated bilirubin, and increased risk for bilirubin gallstones, extravascular hemolysis. Increased risk for aplastic crisis with parvovirus B19 infection of erythroid precursors. Diagnosed by osmotic fragility test, which reveals increased spherocyte fragility in hypotonic solution. Treatment is splenectomy. Anemia resolves but spherocytes persist and Hubble jolly bodies, fragments of nuclear material in RBCs, emerge on blood smear. Sickle cell anemia. Autosomal recessive mutation in beta chain of hemoglobin. A single amino acid chain replaces normal glutamic acid hydrophilic with valine hydrophobic. Gene is carried by 10% of individuals of African descent, likely due to protective role against falciparum malaria. Sickle cell disease arises when two abnormal beta genes are present, results in more than 90% HbS in RBCs. HbS polymerize when deoxygenated. Polymers aggregate into needle-like structures resulting in sickle cells. Increased risk of sickling occurs with hypoxemia, dehydration, and acidosis. HbF protects against sickling. High HbF at birth is protective for the first few months of life. Treatment with hydroxyurea increases the level of HbF. Cells continuously sickle and desickle while passing through the microcirculation, resulting in complications related to RBC membrane damage. Extravascular hemolysis, reticuloendothelial system removes RBCs with damaged membrane, leading to anemia, jaundice with unconjugated hyperbilirubinemia, and increased risk for bilirubin gallstones. Intravascular hemolysis, RBCs with damaged membrane dehydrate, leading to hemolysis with decreased heptoglobin and target cells on blood smear. Massive erythroid hyperplasia ensures resulting in expansion of hematopoiesis into the skull, clear-cut appearance on X-ray, and facial bones, chipmunk faces. Extramedullary hematopoiesis with hepatomegaly. Risk of aplastic crisis with parvovirus B19 infection of erythroid precursors. Irreversible sickling leads to complication of vasocleion. Dactylitis, swollen hands and feet due to vaso-occlusive infarcts in bones, common presenting sign in infants. Autosplenectomy, shrunken fibrotic spleen. Consequences include increased risk of infection with encapsulated organisms such as Streptococcus pneumonia and Haemophilus influenza. Most common cause of death in children. Affected children should be vaccinated by 5 years of age. Increased risk of Salmonella, paratyphi, osteomyelitis. Howell-Jolly bodies on blood smear. Acute chest syndrome, vasocleion in pulmonary microcirculation. Present with chest pain, shortness of breath, and lung infiltrates, often precipitated by pneumonia. Most common cause of death in adult patients, pain crisis, renal papillary necrosis results in gross hematuria and proteinuria. Sickle cell trait is the presence of one mutated and one normal beta chain, results in less than 50% HbS in RBCs. HbA slightly more efficiently produced than HbS. Generally asymptomatic with no anemia, RBCs with less than 50% HbS do not sickle in vivo except in the renal medulla. Extreme hypoxia and hypertonicity of the medulla cause sickling, which results in microinfarction leading to microscopic hematuria and eventually decreased ability to concentrate urine. Lab findings: sickle cells and target cells are seen on blood smear in sickle cell disease, but not in sickle cell trait. Meta bisulfate screen causes cells with any amount of HbS to sickle positive in both disease and trait. HB electrophoresis confirms the presence and amount of HbS. Disease: 90% HbS, 8% HbF, 2% HbA2, no HbA. Trait: 55% HbA, 43% HbS, and 2% HbA2. Hemoglobin C. Autosomal recessive mutation in beta chain of hemoglobin. Normal glutamic acid is replaced by lysine, less common than sickle cell disease. Presents with mild anemia due to extravascular hemolysis. Characteristic HBC crystals are seen in RBCs on blood smear.